Mansi?
I think it's started recording now.
Ma'am, you can start.
Yes. So good evening, one and all. We welcome you to another episode of the Wednesday Special Thyroid Clinics organized by the Indian Thyroid Society. So before we start off with the webinar, let us briefly go through the journey and achievements of Indian Thyroid Society. So Indian Thyroid Society was established and registered in the year 2003. It's a national body of healthcare professionals with special interest in thyroid disorders. Endocrinologists, endocrine surgeons, nuclear medicine physicians, general surgeons, and ENT surgeons are part of the Indian Thyroid Society. ITS is a member of the Asia-Oceania Thyroid Association, that is the IOTA. It has currently nearly 2,000 members. So the executive committee members, the founder president was Professor R.V. Jaikumar sir, and the president at present is the esteemed Professor Sarita Bajaj madam. So other members in the executive committee are the past president, Dr. Rajesh Rajput sir, secretary, Dr. Arun Menon sir, treasurer, Dr. Mini G. Pillai ma'am. So Vice President is Dr. Himagirish K. Rao sir, Scientific Committee Coordinator is Dr. Pramila Kalra Madam, and Joint Secretary is Dr. Sujay Ghosh sir. So the other members of the Executive Committee are Dr. Shashank Joshi, Dr. P.K. Jabbar, and Dr. Krishna Sheshadri. Also Dr. Mohammad Riaz, Dr. Sushil Gupta, and Dr. Ashraf Jani are members of the Executive Committee. So the aims of the Indian Thyroid Society is to organize academic activities for healthcare professionals. It is to promote public education and awareness about thyroid disorders. It is to encourage research in thyroidology, encourage publication in the flagship journal, that is Thyroid Research and Practice, to have state-of-the-art publications, and to award fellowship of the society and to encourage membership of the society. So the ongoing activities of the Indian Thyroid Societies are the CMEs, updates, symposia, and conferences. The thyroid clinics, which were held previously weekly and now being held fortnightly, which include the journal club, case conversations, monologue, dialogue, panel discussion, meet the professor, quiz, workshop, and CPCs. Can we go to the next slide, please? Asmita? The next slide, Asmita. So there are programs organized by the Indian Thyroid Society. One is the Thyroid Awareness Week, which is celebrated between May 22nd to May 28th. We also have the World Thyroid Day celebrated on May 25th. And we have the Thyroid Awareness Month, which is celebrated annually in the month of January. So the research activities of the Indian Thyroid Society include, it provides annual grants for the original research studies focused on thyroid and related disorders, preferably in the Indian context. Research grants are available, and to apply for the grants, it can be accessed in the website, that is the indianthyroidsociety.in. Also, the Indian Thyroid Society has its own journal, that is the Thyroid Research and Practice, which is published twice a year in print and online. It has a quick turnaround time. The electronic copies are available ahead of print. So the Indian Thyroid Society also awards fellowship as well. It is to be awarded to the ITS members with expertise and experience in the field of thyroidology. It will be selected by an expert panel, and the eligible members will be conferred the Fellow of the Indian Thyroid Society. So Indian Thyroid Society also has numerous publications to its credit. The first edition of the ITS Clinical Manual of Thyroid Disorders was published, and the editor was Dr. R.V. Jaikumar sir. Numerous guidelines have also been published by the Indian Thyroid Society, like the Thyroid Dysfunction in Pregnancy, Guidelines for the Management of Thyroid Dysfunction During Pregnancy, Hypothyroidism and Diabetes, Consensus Statement on the Management of Subclinical Hypothyroidism, Guidelines for the Management of Dyslipidemia and Thyroid Dysfunction, and Guidelines for the Management of Depression and Thyroid Dysfunction. So the upcoming publications include the ITS Clinical Manual of Thyroid Disorders, that is the second edition, the chief editors of which are Dr. Sarita Bajaj Madam and Dr. Rajesh Rajput sir. There are upcoming guidelines also which will be published in between 2022 and 23, which include the management of subclinical hypothyroidism, management of thyroid disorders in pregnancy, and management of thyroid carcinoma. So the website of the Indian Thyroid Society is the indianthyroidsociety.in, which has numerous contents that is linked to guidelines. Also, it has access to the ITS journals. It has records of all the academic activities and also the online membership portal. So all MCI registered modern medical practitioners are eligible to become life members of the Indian Thyroid Society. There are two types of life membership which is awarded. One is the full-time life membership, which is basically awarded to the specialists in the field of endocrinology, endocrine surgery, and nuclear medicine. And then we have the associate life membership, where all the other registered medical practitioners will be awarded this particular membership. The applications are invited online on the ITS website, and the details can be accessed by the following link, that is the indianthyroidsociety.in. So without further delay, I would like to ask the IT team to display the quiz participation rules. IT team, can you just display the quiz participation rules, please? Okay. So to participate in the quiz, having a Zoom app on the mobile device or laptop is essential. You are requested to use a laptop for the ease of experience. The quiz will run for about 10 minutes. There will be first 2 dummy questions followed by the actual quiz. The quiz master will display the case or description of the question by screen sharing a PowerPoint file. The participants should use the polls option to participate in the quiz. All 10 questions will be available when the poll is launched, and answer for the quiz will be submitted at once at the end of 10 minutes. To read the case or description, we can use the polls option using the X button, and again use the polls option to answer the respective question. So without further delay, I would like to ask the IT team to display the agenda for today's session. So I think there is some technical glitch going on. So we shall now start off with the webinar. I once again welcome one and all to the exhilarating webinar, that is the Wednesday Special Thyroid Clinics organized by the Indian Thyroid Society. The conveners for the webinar are our esteemed President of Indian Thyroid Society, Dr. Sarita Bajaj Madam, Distinguished Scientific Chair of the ITS, Dr. Pramila Kalra Madam, the Treasurer, Dr. Miniji Pillai Ma'am, and Secretary of ITS, Dr. Arun C. Menon, sir. So today's session will be chaired by the distinguished chairperson, Dr. Sunil Mishra, sir. We have 2 journal club articles presented by Dr. Vishnupriya and Dr. Ghazal Bakshi. This will be moderated by Dr. Nisha Bhavani Madam. This will be followed by the quiz by Dr. Tejal Latia between 8:40 to 8:50 p.m., followed by the monologue by Dr. Alka Singhal between 8:50 to 9:15 p.m. So the answers for the quiz questions will be then discussed by Dr. Tejal after the monologue, followed by the announcement of the quiz winners. So without further delay, let us start off with the first session with the introduction of the eminent chairperson, Dr. Sunil Mishra, sir.
So good evening. Am I audible?
Yes, sir. Yes, sir.
So good evening, and thank you, Dr. Ganavi, and thank you, Sarita Bajaj Madam, always for encouraging us to participate in this particular academic activity. And it's our privilege to be the part of the current academic activity. Yes, we need a pressure to do something, and you know how to extract it from anyone. So thank you for allowing and making us this event to happen. So we have today's 2 interesting journals which will be presented by Dr. Vishnupriya and Dr. Ghazal Bakshi. Both of them are the second year DNB student with us, and they will be presenting 2 interesting articles. One is focusing on the pregnancy outcome and the thyroid hormone level, and the other is on the autoimmune adrenal disease and the hypothyroidism. So I will not take much of the time, and I will introduce my fellow moderator for today. So today we have Professor Nisha Bhavani Madam, and she is a professor in Department of Endocrinology at Amrita Institute of Medical Science, Cochin, Kerala. She is MBBS, MD, and DNB, and DNB endocrinology, and also fellowship in pediatric endocrinology. She has more than 40 publications in peer-reviewed journal and books, and she has a research award more than 3. The other my co-panelist for today is Dr. Tejal Lathia. Dr. Tejal Lathia will be taking care of the quiz. I will just introduce her right now. So she is currently as a consultant endocrinologist at Apollo Fortis and Hospital at Navi, Mumbai. She is DM endocrinology, and her research interest in digital therapeutics, PCO, diabetes, thyroid communication, menopause, women health. More than 18 scientific publications till now, and she is co-authored Language Matters for the People Living with the Type 2 Diabetes and Neonatal Conference paper in other journals. So, and finally, last but not the least, we have our director, Dr. Alka Singhal, and I know Dr. Alka Singhal is one of the pioneer in ultrasonology, and especially when it matters to our specialty like thyroid and parathyroid. So if there is any parathyroid missing in any kind of the imaging, send it to Dr. Alka and she will figure it out. And without her, now we are so dependent on her. Earlier days it is said that if you have a patient with the primary hyperparathyroidism, search for the surgeon. Now we look for the radiologist. So she diagnosed it for us. So she is director in the radiology, Medanta Medicity, and she has a whole body in all specialties of ultrasound, and she runs different course for the ultrasoundology. She has a great zeal and passion for thyroid and parathyroid ultrasound, and she is also been invited from the different international and Indian association to deliver lecture, also write the book chapter. So she has publication and research presentation in thyroid surgery in chapter of the thyroid imaging and journal articles, and more than 20 and so. She's also awarded Bharat Ratna Dr. Radhakrishnan Gold Medal Award for Excellence in Radiology and Imaging 2019. So can I now stop here and go to the actual discussion of today? So over to our DNB residents. Dr. Ganavi, what will be the flow now?
Yes, sir. So I haven't introduced you yet, so
it's fine. So
to display the CV slide of
this is fine. We can go ahead with the.
Okay, go ahead.
Yeah.
I think Dr. Nisha needs to be introduced formally.
Okay. So Dr. Nisha, madam, yes. So sir's CV has been displayed. So sir is the Senior Director and Head Division of Endocrinology and Diabetes at Medanta, the MedCity. Sir has finished his MD from King's George Medical College and DM from AIMS. Sir has about 30 peer-reviewed publications in international and national journals. Sir has been awarded the 6th A.V. Gandhi Award for Excellence in Endocrinology in March 2008 for the best research paper in endocrinology and metabolism. Sir has also been awarded Dr. N.N. Gupta Gold Medal Award for being the best candidate in MD Medicine in 2003. So over to you, sir. I request now Dr. Vishnupriya and Dr. Ghazal Bakshi to start screening their slides and to start off with the Journal Club.
Thank you.
Good evening, everyone. Am I audible?
Yes.
And ma'am, are my slides visible?
Yes, PowerPoint. Slideshow.
Yeah. So should I continue?
Yes, please.
Actually, we'll be presenting 2 journals today. I'm Dr. Ghazal Bakshi from as a second-year DNB resident in Medanta Medicity. So the journal I'll be dealing with will be the trimester-specific thyroid hormone dynamics, iodine reserve, and pregnancy outcomes, a longitudinal study which was published in December 2018 in Thyroid Research and Practice, and which was done by Niku Yadav, Atul Kathed, Dr. Sunil Mishra, Asha Chandola Saklani. Introduction. Non-pregnant cutoffs may not reflect the state of thyroid function appropriately due to physiological changes associated with pregnancy.
The slides are not moving, Ghazal.
Please make it full slideshow on the right side.
The slides are still in editing.
No, it's not.
Are these visible?
Come down. Come down. And the slides are also not moving. Yes, this is better. Okay, fine. Okay, you're in the third slide. Okay, good.
Should I start?
Audio is not good.
Coming to the introduction, non-pregnant cutoffs may not reflect.
Hello. Hello. Hello.
Ghazal, we can hear you, but we can't see your slides.
Ma'am, actually, whenever I start sharing, it goes back to the.
Ma'am, you can start now. Start sharing.
Okay.
Good.
Are these visible now?
Yes.
The non-pregnant cutoffs may not reflect the state of thyroid function appropriately due to the physiological changes which are associated with pregnancy, like increase in TBG, increase in HCG, and the activity of type 3 deiodinase, and the increased renal clearance in pregnancy. Now, the international guidelines have suggested population-based trimester-specific reference ranges for serum TSH through assessment of local population data, including pregnant women with no known thyroid disease, with optimal iodine intake and negative anti-TPO antibody status.
Hello. Hello. You can see your editing mode. Hello. Hello, Dr. Ghazal. Yeah, now you can share. Click on share. Go to the basic and then screen share. Screen editing mode.
Maybe the internet is not sustaining. Better switch off your video and then probably it will be better. So
Can we do the second one while she's getting ready?
Now you can click on share slideshow ma'am. Yeah.
This is
Yeah, it's coming and it's moving.
Perfect, ma'am.
I told that international guidelines have suggested population-based trimester-specific reference ranges for serum TSH through assessment of local population data, including pregnant women with no non-thyroid disease, optimal iodine intake, and negative TPO antibody status. Now we know that if a pregnant woman is taking low iodine, then thyroid function tends to adjust itself from physiological adaptation to any pathological derangement depending upon the degree of the iodine deficiency. And that is why there is a paucity of data addressing the impact of iodine deficiency on thyroid hormone dynamics and trimester-specific cutoffs in pregnant women. Now, coming to the study design is the aim of the study is to assess the thyroid hormone ranges and pregnancy outcome in a mild iodine deficient population. It was a longitudinal follow-up study which was done in rural region of district Gurgaon, Haryana, which included mild iodine deficient zone in 13 villages of Gurgaon. The study duration, this survey was from 2012 to 2015, but they also collected data for past 10 years for pregnancy outcomes from the government health records in these 13 villages. Coming to the study population is the pregnant healthy females 19 to 34 years of age visiting these primary health center from these 13 villages. Exclusion criteria. This study excluded patients with history of previous history of thyroid disease or overt hypo or hyperthyroidism, patients who were on thyroid medication or who were on medication that might affect thyroid function, patients with chronic illness, that is hypertension, renal disease, diabetes, or hyperemesis gravidarum, patient with history of miscarriages, and patient whose anti-TPO was positive. And they took a cutoff of more than 50 international units per ml. Coming to the methodology, primary information was obtained on 450 pregnant women. After being subjected to the exclusion criteria as mentioned before, 340 subjects completed the study. 50 non-pregnant subjects were also enrolled from the same population with similar demographic characteristics to serve as an indicator of baseline preconception values of the pregnant women. Pregnant women were followed and data was generated in 10th, 20th and 30th week of gestation. Information which was collected from the subjects was their demographic profile, their socioeconomic profile, physiological profile and clinical features. Now, how did they assess the thyroid status? For thyroid status, they clinically examined for enlargement of the thyroid by palpation method, sample collection and storage. Finger prick DBS, that is the dry blood spot serum, was collected. All hormone assays were performed together in lots at the end of the study to reduce any inter or intra-assay variation, and they all were done by the same assay and they used second generation ELISA. Reports were blinded to reduce bias and were unknown until after the completion of pregnancy. Urine samples were collected in sterile containers and transported to the laboratory at 0 to 4 degrees Celsius, where they were stored in refrigerator until the analysis by Sanger-Kolthoff reaction spectrophotometrically. Coming to the statistical analysis, the estimated adequate sample size came out to be 332, and they took around 432 women. Data for TSH and FT4 were expressed as mean plus minus standard deviation, median, and 2.5 to 97.5th percentile. Urinary iodine concentration data was expressed in median and again 2.5 to 97.5th percentile. All the hormonal values which came out were calculated and compared among the trimesters. Students t-test followed by Bonferroni post-hoc analysis and Pearson correlation analysis were the statistical tests performed for comparison. Coming to the results, first of all, they studied for the urinary iodine concentration to define whether the population was iodine deficient or not. In this, they found that when they started the study with 340 females, in first trimester, around 56% of the females were under mild iodine deficiency as per the WHO norms. That is, they have urinary iodine concentration less than 150 microgram per liter. As the trimester progressed, in third trimester, around 91% of the female came under the mild iodine deficiency status. So overall, 91% pregnant females were iodine deficient in this population, with only 9% iodine sufficient in the third trimester. And the non-pregnant women which they took, in that also around 50% women were iodine deficient. Now coming to the calculation of reference ranges, the reference ranges taken were from 2.5 to 97.5th percentile of the population as described by the guidelines. And in this, what they found is, they calculated is the TSH of non-pregnant female, those who were around 50, and the TSH of in trimester 1, trimester 2 and trimester 3. Now they found that as compared to the non-pregnant, where the TSH range was 0.67 to 3.58, in trimester 1, the lower cutoff increased to 1.02, which gradually increased in all the trimester and was up to 2.2. Now, normally, what as per the physiology, what we know is that with that TSH gradually decreases with the lower cutoff of TSH decreases in the first trimester, but this raise was expected due to the mild iodine deficiency which the subjects have. If we see the upper limit, then we can see that gradually the upper limit is also increasing. That is, in trimester 1, it was around 3.7. In trimester 2, it was around 4.83. And in trimester 3, it was around 5.74. Also, there is an increase in the TSH cutoffs in the overall median. Then, with further analysis, they found that about only 2% of the population constitutes outlier in all trimesters. That is 6 subjects in first trimester and second trimester, and 7 subjects in the third trimester. So therefore, any women falling beyond cutoff of this cutoff, that is 2 to 4% population, may require further evaluation and treatment. Now, next, moving to the free T4 level, which were calculated. Again, they compared in all the trimester and with the non-pregnant, that is the pre-pregnancy T4 cutoffs. Here they found that if we consider the percentile again from 2.5 to 97.5, the initial cutoff was 10 to 18.56 picomole per liter. Then this lower cutoff, this keep on decreasing with the trimester, that is 10.3 in first, 9 in second, and 8.2 in third. And if we see the upper limit, it also decreases gradually with the trimester, which is also explained in the other patients with iodine sufficient status. So they concluded that FT4 level in 81% pregnant patients lies in more than 10 to 20 picomole per liter, while 19% of the patient have FT4 from 8.2 to 10 picomole per liter. But this 19% also comes under the 2.5 to 97.5 percentile range. In the current study, at 2.5 to 97.5%, approximately only 1 to 2% FT4 values were obtained as outliers, and 98 to 99 was within the lower limit of FT4 cutoff. And then they further analyzed, and they found that the decrease in FT4 and increase in TSH between the trimester, all of the values when compared were statistically significant. Coming to the distribution of TSH values within the normal percentile interval, that is 2.5 to 97.5. This is the TSH values plotted again the frequency of the patient. Now, if we consider, this is first trimester, second trimester, and third trimester. Here we can see that in first trimester, the lower cutoff of TSH is around 0.75 to 0.75, and it is gradually increasing with each trimester. And also the upper limit is gradually increasing with each trimester, with around 5.75 in the third trimester. So we can see the increasing TSH trend. One more important point as per the study was that TSH level in third trimester, if we concentrate here, then we can see that around 30% of the patient, they lied from more than 5 to 5.8. More than 4 to 5.8. 4 is the usual cutoff which we take if we don't have any trimester specific cutoff as per the ATA guidelines 2017. Now, here we can see around 30%, which is a big number of patients who lies in this range. Then they concluded that approximately 98% lies in upper limit TSH cutoffs, that is 3.7 in first trimester, here 4.8 in second trimester, and 5.74 in the third trimester. According to the international guidelines, a much higher number of patients will require treatment. Coming to the pregnancy outcome. For pregnancy outcome, they retrieved data from government primary health center record, and they studied around 1,600 patients, in which they saw the rate of miscarriage, stillbirth, and premature birth. Goiter rate was not available. And when they compared it with the patient from this survey, they found that it was almost comparable in the patients studied in this survey from the normal population. So the present, and also this data of stillbirth, that is around 1.5% in these patients, it was in harmony with that reported from different Indian states. Pregnancy outcome in the follow-up longitudinal study, when actually here they studied around 438 patients, which they took initially, but finally in the study they took only 330 patients who completed the profile. So out of those 340 patients, there was 100% successful pregnancy outcome, which even in the patient, these 1.1% patient who developed goiter, there was no incidence of miscarriage, preterm delivery, and stillbirth. Coming to discussion, here we can observe that despite iodized salt intake, which was evident from the questionnaire survey, urinary content reflected mild iodine deficient status as per the WHO norms in this studied population. Limited information is available on how iodine status affects TSH reference interval. Data indicate a significant consistent rise in TSH throughout the trimester, resulting in higher TSH thresholds. As per the virtue of International Federation of Clinical Chemistry, in this study, 98% population, that is 333, lies within upper limit TSH cutoff, that is 3.7, 4.8, and 5.74 in first, second, and third trimester. Coming to the limitation, one of the limitation can be the assay used for TSH in free T4 levels, but still the assay was same for all the patients. That is, there was no difference in the assays. Second can be that the correlation between pregnancy outcome and TSH level above the international cutoff can provide a better insight. If we consider trimester specific TSH values found in different Indian studies, so there are various studies which were done. One is by Marwa et al., by Rajput et al. What we can see is in all these studies, all these studies were done on patients with iodine sufficiency, or either iodine sufficiency was confirmed or iodine sufficiency was assumed in these studies. Most of the studies are cross-sectional, but this one was longitudinal. So if we see these studies, here we can also observe that with third trimester, the lower limit of TSH is increasing in almost all the studies. Done in Delhi, Haryana, Kolkata, Nagpur, or in all these studies, the TSH levels are on a higher side. So concluding, iodine deficiency appeared to enhance the cutoff of TSH. Thyroid function remains unimpaired in continued mild iodine deficiency during pregnancy as a result of efficient homeostasis. Study underscores the need for indigenous population-specific ranges to avoid misclassification errors. Last is that status of iodine sufficiency in India has been explained by WHO, but if we see individual status as per the National Iodine Program, we can see that in every state, some cities or some villages are under still mild iodine deficiency state.
First, Dr. Nisha Bhavani, madam, to give her expert comments.
Thank you, Dr. Gaisel, for that lucid presentation. So this is what the authors have told about the study. So what is your interpretation of the study? What are the strengths and limitations? What do you think?
Ma'am, as per we are concerned currently, definitely we are following the ATA guidelines if we don't have a trimester specific cutoff. But from this, what I have observed that sometimes there can be an over diagnosis of thyroid insufficiency in pregnant patients, which can be avoided if we have trimester specific cutoff. Second, which I took was that iodine status cannot be confirmedly said that yes, iodine status of that population is normal, because for every in different places in India, I believe that heterogeneity will be there in iodine status of the population.
Yes, I completely agree with you, Dr. Gaisel. It underlines the importance of assessing of making trimester specific ranges for each population, because each population is different. But I would say some methodological flaws in the study. One is that they determine the TSH using the heel prick blood test. And they haven't specified whether that is a, the conversion between serum and dried blood spot, whole blood and.
And actually, they have said that the hematocrit which they used for the conversion, that was around 50, that conversion factor they took was around 15, which they took for this.
How much?
15.
The usual conversion factor is 2.2 for adjusting for the hematocrit which we use in newborn screening. I don't know why such a difference is there. So probably for trimester specific rather than dry blood spot, serum would have been better and the LCMS would have been the ideal choice. The assay is the one. So you repeat this TFT. We know from our clinical practice, if you repeat a TSH in 2 different labs, same sample, it will come as 2 different things because the assay interference is the most important. Roche will give a different cutoff, Abbott will give a different cutoff. So assay is the most important. And then this mild differences, that is subclinical hypothyroidism in pregnancy, the normal TFT. It is always controversial whether to treat or not. Between the upper limit of normal and the and less than 10, whether to treat or not is an individualized decision, even according to the ATA. And it's because it doesn't contribute to the stillbirth or low outcome. It may cause a difference in the neurocognitive function of the offspring. As my Jayama sir, my professor and my teacher always say, if you have a subclinical hypothyroidism, maybe your child will get 10th rank instead of first rank in the 10th standard exam. That is all the difference which you get if there is a mild change in TSH, which we don't know. We don't have data yet to prove or disprove that. So telling that this doesn't affect the stillbirth and the miscarriage and all, may not, with this small difference, it may be too much of an extrapolation is what I thought. And this methodological method of assessing the TSH also probably in a population study, for large population study, dry blood spot will be, that is all what is feasible in our setup. So it is definitely better than nothing. But then it is not the ideal thing to be done, is my opinion on that.
There is a question in the chat box. I think, Dr. Nisha, we should address it from Dr. Jagbi. Please look at the chat box.
Yeah, the question is this study have treatment implications? Like, for example, one patient with increased TSH above the cutoff, should we measure iodine also or just supplement the levothyroxine? That's the question.
So that is a very important point. So because individual urine iodine excretion has no value in clinical practice. It is a population study. It is the median iodine concentration of a population which determines the iodine status of the population. You do my iodine excretion using 24-hour urine iodine or spot urine iodine today and tomorrow, it will be grossly different. So there is no place for urine iodine excretion in an individual clinical practice. So I be above the cutoff and the upper limit of like upper 4 and above, between 4 and 10, whether to treat or not. It is an individualized decision. Mainly we base our decision on anti-TPO antibody status. And if you are not treating, we'll all follow up to see whether it is increasing. So always try to repeat it in another lab using another assay, which if you know your lab well, you know which assay they are using, whether it is Roche or Siemens or Abbott or something, and then you try using a different assay and repeat the TSH. If it is persistently high, you can think of treating. The risk of treating is not very great. That is why ATA has recommended that you can even treat small rises above the upper limit of norm.
I think we should move on to the next one, please.
Yeah, so we move on to the quiz now. So
no, there is
second
one more
journal,
article.
second journal club is there. Yeah, second journal. Yeah. I think we have to little bit be faster. So because we're a little bit behind time.
Everyone, can you hear me?
Yes.
Full screen.
Yeah, slideshow.
Dr. Pramila, what you put 40 minutes, 2 cases, I have been observing is not sufficient. There is no hurry at all. Please keep, because if you don't discuss, there is no point in.
Right, sir.
Better give 30 minutes, even if
Okay.
it is 1 or 2. Everybody's question should be answered, or we should discuss. Otherwise, anybody can read the paper and have their own conclusion. So
Sure,
give
sir.
30 minutes, even if you reduce other things, it is
Okay,
better,
sir.
because we have been finding that 40 minutes finishing 2 cases is not, even if you have one probably article, 40 minutes is still good enough. We can
Right, sir.
for half an hour discussing this. As Dr. Nisha has said, there are so many things that you can
Right.
discuss in it. Iodine deficient, afferent sufficient, there's no difference at all. It doesn't make any difference. Then treatment strategy, whom to treat or not. Cutoffs, Indian this one. Though it has limitation, it's a good paper. Lot of less.
Right. Fine, sir. We'll increase the time for this thing next
Dr.
time.
Vishnu,
onwards.
enable editing and then go to full screen. You have not enabled editing. Yeah. Quickly press on it.
Enable editing, you just press on that. And now
then,
go
yeah,
to full screen.
full
Yeah,
screen.
now full screen. Yeah. Full screen, you have to press down, where there is that 100% next to that.
Or you can go to slideshow, view, review, and slideshow animation. Next to animation slideshow. Yeah, in the beginning.
Yeah. This is fine.
Not moving.
Ma'am, I'll stop your sharing now. Let's share. Now you can share. Hello. Hello. Yeah.
Go ahead.
Yes.
Yeah.
Sure.
We can see now.
Quickly.
Okay.
You are not audible.
You are mute, Vishnu Priya, you are mute.
Sorry, Dr. Vishnupriya, I'm not audible.
Hello. Is it audible now?
Yeah, we can hear you, but
Faintly,
little bit
yes.
distant. Little bit distant, not very clear, but you can try speaking. We'll see if it is audible better.
Original article from JCE published in 2022. Autoimmune medicine disease, autoimmune thyroid disease, and autoimmune editing disease.
You are audible at a distance. Are you using a earphone which is not well connected or something?
Use cord.
The speaker volume, like, is it less or something? Just try to adjust that.
Hello.
Can you hear me, ma'am?
Yes,
Now it's better. Yes, yes.
Ma'am, I will be presenting.
Go ahead, Ghazal.
Sorry, not audible.
You're not
Vishnupriya.
audible at all.
Can we move to the quiz and come back to this later?
Yes.
We'll do that.
Yeah.
So what we'll do by the time she adjusts her the technical thing, we'll have the quiz and then we'll come back to this. Is that okay?
Tejal? Yeah. So, Mansi, can you flash the quiz?
Yes, ma'am. Yes,
please?
ma'am. Yes.
Yeah.
I have the slides, so I can also share it. It's not a problem.
Okay, then you can read them out as well, please, Tejal.
Yes, ma'am. I have the slides.
Okay,
Wait
great.
1 second. Yeah. Okay, I'm ready. Mm. Is this clearly audible and visible?
Yes, yes.
Okay.
Yes,
We
absolutely.
need to have the rules flashed first.
Ma'am, first we need to flash rules and then we can start the show.
Yeah, let's have the
Sure.
rule. Yeah, just wait, Tejal, till she's told about the rules. Pramila, can you read them out, please?
Yeah, so first thing is that there are a few rules which everybody has to follow who is participating. So first thing is you should have a Zoom app on your mobile device or laptop, which is essential. And you should better use a laptop for the ease of experience. It will make your job easy. And the quiz will run for around 10 minutes. And first there will be 2 dummy questions followed by the actual quiz. And the quiz master will display the case or the description of the question by the PowerPoint, and that will be there. Participants should use the poll option to participate in the quiz. All 10 questions will be available when the poll is launched, and answer for all the questions is to be submitted at once at the end of 10 minutes. And to read the case or description, you can close the poll using the X button and then again use the polls option to answer the respective question. So you can do like that. So I think people who have been doing it regularly know it, but the new ones can just do it. So we'll just have a dummy question and then we go ahead with the quiz.
And the answers will be at the end of the entire session.
Yeah.
So dummy polls are launched.
So these are the 2 dummy questions. Yeah.
Can we start now?
I think we can start. Dr. Tejal, you can share. Yeah.
So good evening, everyone. And it was extremely difficult to find questions because a lot of other quiz masters have given amazing questions before this. So the first question, ma'am, should I read out the questions?
Yes, please. Yes, please.
So an 18-year-old girl presents with a painless 1 centimeter mass in the anterior neck region. A biopsy was taken which reveals fluid contained within pseudo-stratified columnar epithelium. What is the most likely diagnosis? There's a single choice and the options are there for you to see. Follicular adenoma, branchial cyst, thyroglossal duct cyst, thyroid cystitis, or a parotid gland tumor. This question is a little unfair because it's a thyroid quiz, so the choices are really only 2.
That's just 10 seconds and then we move on.
We move on. Okay. I'm sorry, this is a little elaborate, but basically the question is about medullary thyroid carcinoma. I've given you 4 options and I need you to select the one which is incorrect. So the overall survival rate for medullary thyroid carcinoma is approximately 50%. I've named 2 multi-target tyrosine kinase inhibitors. These are used for the treatment of medullary thyroid carcinoma. That's cabozantinib and vandatinib. If the pre-op value of calcitonin, I'm sorry, I forgot to write calcitonin, pre-op value of calcitonin, if it's less than 100, and if the post-op value is less than 5, this signifies a good prognosis. An absence of laterocervical lymph node metastasis at diagnosis signifies good prognosis. You need to select one option which is incorrect. I will move on to the next question. I hope I'm not going too fast. Now, we all know that we're very excited in the field of thyroid-associated ophthalmopathy, that we have a new drug that we could use. I'm sure most of you have discussed this in your journal clubs. So in the randomized control trial published in the NEJM about teprotumumab, which statement again is false? So 1, it is an IGF-1 receptor inhibitor. Second is you can read the option, but this was the protocol that was used in the study. 10 mg per kg of the medication in the first infusion, 20 mg per kg in the subsequent infusions, and a total of 8 infusions were given once every 3 weeks for 21 weeks. The result of the study is 83% had an improvement in proptosis as compared to 10% in placebo. And in the study, the outcome measure was a reduction in proptosis by at least 3 millimeters and reduction in the clinical activity score by at least 3 points. So you have to tell me what is false regarding the study. The next question, I'm sorry to put some veterinary medicine in it, but I recently have a dog and I'm very interested in now veterinary medicine. So I need you to tell me, which I know most of you won't be able to get this, but anyway, which is incorrect regarding thyroid disease in animals. So hypothyroidism is quite common in dogs, and the most frequent cause is lymphocytic thyroiditis. The most common cause of hypothyroidism in cats is actually iatrogenic. Foals have a rare congenital hypothyroidism syndrome with some musculoskeletal abnormalities. This is because when the mothers graze on high nitrate diet, the pregnant mare, the foals get congenital hypothyroidism. And the dose of levothyroxine in dogs is 2 to 4 mg per kg body weight. I'm sorry for this, but I just could not resist this question. Okay, the next one. So these ones are now easier. So we all know that Dr. Ghosh and his group has published a study in Journal of Clinical Endocrinology and Metabolism, where they looked at plasma cell-free DNA to differentiate between malignant and benign cells. I'm sure all of you have discussed this paper in your journal club. What was the cutoff for the cell-free DNA, which yielded 100% sensitivity and 93% specificity to differentiate between malignant and benign nodules? 57.9, 67.9, 77.9, or 87.9 nanogram per ml.
Hello, Max. Your slides are not moving. It's still showing thyroid place, Dr. Teja, the first slide.
I was just doing the poll because I thought the poll, if it is being seen. Okay, sorry. Okay.
Yeah, I think if the poll is seen, it's fair enough because we can see from the poll.
Exactly.
So the slides are there. So we don't need the slides to move because the poll itself has all the questions and the things. Okay. So I think that's okay. Yeah,
it's okay. So this is again an article which is recently published in the JCEM, and they looked at pesticides in thyroid cancer, and this was done in California and the US. And these were the pesticides which possibly have been implicated in the genesis of thyroid cancer. You need to select which is the pesticide which has not been associated with the genesis of thyroid cancer. Paraquat hydrochloride, oxyfluorphan, carbon tetrachloride, and glyphosate. Okay, this is a study which was published in the Thyroid Research and Clinical Practice. I remember we reviewed the paper, Dr. Selvan and I. And what is the mean drop in TSH in the postprandial state? So from between the fasting to the postprandial, what is the mean drop in TSH? 0.1, 0.3, 0.5, or 0.7? This has clinical implications. So the TRUST trial, this was published, I think, in the BMJ, and this evaluated the treatment of subclinical hypothyroidism in a group of subjects with levothyroxine, and they looked at what was the impact on the symptoms and whether there was any improvement in the symptoms. So you need to tell me which was the group of subjects in which this trial was conducted. So was it pregnant women? Was it elderly patients? Was it children? Or was it people with cardiovascular disease? Okay, the next question. So in the Chernobyl nuclear accident, which occurred in 1986, which was the radionuclide with the greatest impact on an increase in thyroid cancer? So all the different radionuclides are there in front of you: iodine 131, tellurium 132, iodine 133, or cesium 134 and 137. Which was the one which had the greatest impact on an increase in thyroid cancer? I'm not going to ask you to identify the histopathology slide because I find that very difficult myself, but just to give you context. So this is basically a slide of diffuse sclerosing variant of papillary thyroid carcinoma. Can you tell me which is the molecular alteration most commonly found in the diffuse sclerosing variant of papillary thyroid carcinoma? I won't read out the options, but please select the appropriate option. This is the last question, and then I'll be closing the quiz. Okay, so thank you everyone, and I will be back with the answers at the end of the session.
So I think we can move ahead with the next presentation of General Club if Dr. Ghazal is ready. Yeah, so we can see if we can try sharing the slides now and see.
Yeah, your voice is not coming again. Audio.
Hello, can you listen? Can you hear me? Hello.
Yes.
Yes, you can hear.
Good evening, everyone. I'm Dr. Vishnupriya from Medanta Medicity. So I will be presenting this journal, which is Autoimmune Thyroid Disorders in Autoimmune Addison Disease, published in JCM, June 2022. Autoimmune Addison disease is associated with autoimmune polyendocrine syndrome in more than half cases. As per Swedish Addison registry report, hypothyroidism was the most frequent concomitant disease affecting 40% of patients, while Norwegian registry reported that 41% had hypothyroidism and 5.7% had hyperthyroidism. And Italian data reported that 68% had concomitant autoimmune thyroid disorders, but they also included patients with thyroiditis on ultrasound and anti-TPO positive patients with normal TFT. So detailed investigations of the prevalence and clinical course of patients with autoimmune thyroid disorders along with autoimmune adrenal disease are lacking. To provide comprehensive epidemiological and clinical data on autoimmune thyroid disorders is the objective in autoimmune Addison disease. A nationwide registry-based study, including 442 patients with autoimmune adrenal disease and autoimmune thyroid disease, were identified through Norwegian National Registry of Autoimmune Diseases. Data was compiled from the registration end of 2021. Patients with combination of autoimmune adrenal disease and autoimmune thyroid disorder, both Hashimoto's or Graves', were enrolled in Norwegian registry for organ-specific autoimmune diseases. And patients with primary adrenal insufficiency and antibodies against 21-hydroxylase or presence of associated autoimmune diseases were classified as having autoimmune adrenal disease. And both data from both registry, hospital, and self-reported information from the patient were taken regarding thyroid disease. Patients with primary adrenal insufficiency of other causes were excluded. Patients who were found to have non-autoimmune hypothyroidism, for instance, after cancer surgery or treatment of nodular disease, were excluded. 912 patients with autoimmune adrenal disease were included. 442 patients had probable autoimmune thyroid disease. Thyroid hormones at onset were obtained from 203 patients out of 380 patients of hypothyroidism. And information on anti-TPO antibody were missing from 3 patients out of 380 and in patients with hypothyroidism, and thyrotropin receptor antibodies were missing from 17 patients out of total 78 patients of Graves' disease. Sex, age, year of diagnosis, concomitant autoimmune diseases, autoantibody status, and treatment was noted. Medical records were validated by endocrinologists, except in 4 cases where they were from unknown site. Presence of autoimmune hypothyroidism, autoimmune hyperthyroidism, type 1 diabetes, B12 deficiency, primary gonadal insufficiency, vitiligo, celiac, and alopecia was recorded. TSH-free T4 at onset and TPO antibodies during the course of the disease whenever available was noted. Subclinical hypothyroidism was divided into two categories, mild and severe. Subclinical hypothyroidism was TSH greater than 4 milli international unit per liter and FT4 within the reference range. And mild was 4.1 to 10 and severe was TSH more than 10. Overt hypothyroidism was defined as TSH greater than and FT4 less than the reference range. Hyperthyroidism was diagnosed with Graves' disease by their attending physician and obtained information on thyrotropin receptor antibody levels, presence of orbitopathy, remission rates, and treatment given if remission was not achieved. Patient who had coexisting disease. These were patients who initially had hypothyroidism and were treated and later on developed Graves, or who initially had Graves' disease, went on to remission, and then developed autoimmune hypothyroidism. Registry of organ-specific autoimmune disorders. Biobank serum samples are routinely analyzed for 21-hydroxylase autoantibodies using radio-binding ligand assay. This is the flow chart. The Norwegian Registry of Organ-Specific Autoimmune Diseases. Total number of patients were 1,456 between 1996 to 2021. Out of this, 545 patients were excluded who did not have adrenal insufficiency and who did not who had secondary adrenal insufficiency or primary adrenal insufficiency of non-autoimmune etiology. 912 patients were diagnosed with autoimmune Addison disease. Out of thyroid with thyroid disease of non-autoimmune etiology were excluded, and we got 442 patients who had autoimmune Addison disease and probable autoimmune thyroid disease. This was around 48%. Out of 912 patients of autoimmune adrenal disease, 42% patients had both autoimmune hypothyroidism and autoimmune adrenal disease, while 9% patients had autoimmune adrenal disease and Graves' disease. While coexisting disease, autoimmune hypothyroidism and Graves' disease were present in 2% of patients. The results of the study, as we can see in the table here, prevalence of hypothyroidism was 42% in patients of autoimmune adrenal disease, and 8.6% of Graves' disease was seen in patients of autoimmune adrenal disease, while the prevalence of female patients was similar in both hypothyroid and Graves' disease, which was 71% in hypothyroidism and 77% in Graves' disease. The age of onset of autoimmune adrenal disease is seen more in younger age group in Graves' disease, which is 33 years. And the age of onset of autoimmune thyroid disease, again, is seen more in more younger patients in Graves' disease, that is 33 years. In autoantibodies, 21-hydroxylase antibodies were positive in 95% patients of hypothyroidism and 96% patients of Graves' disease, while TPO antibodies were positive only in 68% patients of hypothyroidism and 55% patients of Graves' disease, while TSH receptor antibodies was present in 82% patients of Graves' disease. Basic demographic about autoimmune disease. As we can see here, type 1 diabetes is the most common disease associated with both autoimmune thyroid disease and autoimmune adrenal disease. In hypothyroidism, type 1 diabetes is present in 18% of patients, and in Graves' disease, it is present in 15% of patients. While vitamin B12 deficiency is next in line, with 9.5% of patients of hypothyroidism having B12 deficiency and 15% patients of Graves' disease having B12 deficiency. Gonadal insufficiency was seen in 6.8% of hypothyroidism patients and 5.1% in Graves' disease. More than one associated disease was present in 49% patients of hypothyroidism and 56% patients of Graves' disease. This is a bar chart illustrating temporal relationship between onset of autoimmune Addison disease and hypothyroidism in 361 patients out of 380 patients. Rest of the patient data was missing. So here we can see that 31% patient had simultaneous onset with autoimmune adrenal disease, while 34% patient had hypothyroidism before the onset of autoimmune adrenal disease, and 35% patients had onset after autoimmune adrenal disease. So it's nearly the same in all the three groups of autoimmune adrenal disease with hypothyroidism. This is another bar chart illustrating the temporal relationship between onset of autoimmune adrenal disease and hypothyroidism in 76 of 78 patients. So here, there's a difference. We can see here that 17% only had simultaneous onset with autoimmune adrenal disease, while 42% had onset before autoimmune adrenal disease, and 41% had onset after autoimmune adrenal disease. This is for hypothyroidism. Now, here in this table, we will see the degree of thyroid dysfunction versus temporal relationship between onset of autoimmune Addison disease and hypothyroidism. So here, overt hypothyroidism is present in 34% patients before the onset of autoimmune Addison disease, while simultaneous onset was present in both overt hypothyroidism and subclinical hypothyroidism with TSH more than 10 in 50% patients. While onset after autoimmune adrenal disease, the most common is subclinical hypothyroidism with TSH between 4.1 to 10, which is again 51%. This table is again showing thyroid TPO antibody status versus temporal relationship between onset of autoimmune Addison disease and hypothyroidism. Here we can see that TPO antibody is negative in 35.7% patients who had onset of hypothyroidism before autoimmune adrenal disease, while 27% had TPO negative in simultaneous onset with autoimmune adrenal disease, and in autoimmune adrenal disease onset after hypothyroidism onset after autoimmune adrenal disease, 30.6% patient had TPO antibody negative. This is again a table showing degree of thyroid dysfunction versus TPO antibody. TPO antibody in 203 of 380 patients with available TFT. Here, TPO negative antibody is seen in 21.4% patient with TSH in normal range, and TPO negativity is also seen in mild subclinical hypothyroidism with TSH between 4.1 to 10. Here also TPO antibody negativity is around 24.5%, while patients with severe hypothyroidism, TSH more than 10, had TPO negativity only 16%, while overt hypothyroidism patient had 19.5%. Total overt hypothyroidism patients were 20%. Limitations of the study: considerable amount of mixing data of both thyroid hormone values and autoantibodies in the study. The use of different assays for measuring thyroid antibodies because they were done at different sites at local hospital. Conclusion of the study: even if autoimmune thyroid disease is the most common autoimmune comorbidity in autoimmune Addison disease, overt hypothyroidism was seen in about 20%, and Graves' disease was seen in only 9% of cases. So careful consideration is needed for indication to start thyroxine, especially in patients with mild subclinical disease or negative TPO antibodies. And risk of developing type 1 diabetes is high at 15 to 18%, indicating annual screening for HbA1c and glucose monitoring. And more than one associated disease was seen in 49% patients with hypothyroidism and 56% patients with Graves' disease. Thank you.
Thank you, Vishnupriya, for that presentation. Did it change the journal because I was sent another journal of LT4 therapy in pregnant women? I didn't see this journal. It's okay. So again, I think this is a good data of a population registry showing autoimmune adrenal disease, and it has got the limitations of this population registry. Can I ask you how many this type 1 diabetes, whether it preceded autoimmune Addison's or it was after autoimmune Addison's? Do they have data on that?
Ma'am, about type 1 diabetes, no, ma'am, they just had data regarding how many percentage of patients were there with hypothyroidism and Graves' disease. They were basically comparing thyroid disease in autoimmune adrenal disease.
Yeah, okay. Because usually what we see is in type 1s, when we usually keep them under follow. We do see them developing thyroid disease and very rarely Addison's disease. We don't have facility to do 21 hydroxylase antibodies in India, so we are not able to confirm a diagnosis of autoimmune adrenal disease easily in India. But I think we should remember that even frank Addison's per se, there is a slight increase in TSH at diagnosis. A subclinical hypothyroidism is common in untreated Addison's disease because of the Addison's per se. Just like you have a central hypothyroidism in Cushing, in an Addison's you have a subclinical hypothyroidism like picture. So that needs to be kept in mind while interpreting the thyroid function test.
So there are questions in the chat box.
No, there are no questions as of now in the chat box.
Yeah, there is.
In question answer, there is a question.
Yeah.
Any cases of pernicious anemia?
Pernicious
That's
anemia.
one question. And the other one is association with autoimmune pituitary involvement was looked for or not?
In the registry, there was no report of autoimmune pituitary involvement, but vitamin B12 deficiency was observed in both Graves' disease and hypothyroidism, much commoner in Graves' disease.
There is one more question. Association with autoimmune pituitary involvement was looked for or not?
No, sir.
She told.
Yes, she has already answered.
Anywhere 21 hydroxylase is being done, other respected faculty, anywhere it is being done.
I think we had seen 25 years back that Chandigarh PJ was the only one. They were doing all antibodies. We used to send our samples for one of the FSH trial vaccine, where they had the necessary infrastructure. I forgot the name of a lady who was the professor of pathology. She used to do all anti-FSH antibody, LH antibody. So all the anti-pituitary antibodies she was doing in Chandigarh.
On a research setting, STPJ also used to do Ishpatiya sir as part of his AIR thesis, AIR mutation studies. But then on a commercial basis for a patient, when they come to us, it's very difficult to get. Quest used to do it previously, but now after COVID, the Quest collection centers have closed down, at least in Kochi.
Most of our patients are tuberculosis, I think, for adrenal Addison's disease. The most common cause in India per se is tuberculosis, because my project was in AIMS. One of my projects under Dr. Amini was looking at adrenal glands in patients of extensive pulmonary tuberculosis. Dr. S.K. Sharma was my co-guide, and we found really huge adrenal masses, bilateral adrenal masses in patients with pulmonary tuberculosis. So that, I think that should be looked for.
So
Can we
no.
move on to the next session? Because
yeah,
I think we have no further questions.
Yes.
So if
we are waiting for Dr.
Dr.
Alka.
Sunil can introduce the next.
So I have already introduced Dr. Alka in the beginning, but Dr. Alka is the director in Division of Radiology in Medanta, the Medicity, and she is a prolific speaker, researcher, teacher as well, and she runs the sessions for ultrasonography with the students. And she, thank you very much for taking out your time today. You are already conducting one session on the ultrasonography. So I'm again reiterating that once we diagnose a patient of the primary hyperthyroidism, next job is to search for Dr. Alka to pick the gland. So that's what we are totally dependent on her for any kind of the intervention, and you will see how she is going to teach us today about this different kind of the thyroid abnormality in radiology. So over to Dr. Alka. I will not wasting more of time here.
Thank you so much, Dr. Mishra, for such a kind and a warm introduction. And thank you, Dr. Sunil Mishra and Dr. Sarita Bajaj, for inviting me over, and the entire Indian Thyroid Society. I mean, thank you for all the great referrals that you sent to me. Thank you for all the constant feedbacks that you give to me, empowering me to do better and better. Thank you so much. So let's look at the thyroid ultrasound case-based review. That's the topic that I've been given to. I mean, thyroid is like my passion. It's just my core of my heart. Like, okay, I'm always excited for more and more, to be honest, for some reason. Don't know why. Thyroid and parathyroid, they do excite me. So coming to the normal ultrasound anatomy, it's like an H-shaped gland that drapes over the trachea, and it appears smoothly, diffusely homogeneous, and we can see the carotids, and we can see the esophagus, which can be right or left-sided structure depending on the tilt. And of course, we can see the isthmus, and we can see the thyroid cartilages. We are able to predict extrathyroidal extensions, and then of course further suggest further imaging. So evaluating the vessels, evaluating the parenchyma, evaluating all the other structures of the neck, that's our responsibility. Just how a normal thyroid looks like: diffusely, smoothly, homogeneous. That's the trachea and the midline. That's the inferior strap muscles, and that's thyroid parenchyma. A normal thyroid that's not enlarged, it's got a mild concave contour, and that's like a mild concave contour, which fills up the earliest when we see thyromegaly or a diffuse enlargement. This is, of course, a normal scan. Now, of course, in an endocrine conference, this slide is totally out of place, but it just fills up because for us as radiologists, for everybody to know the clinical scenario of the patient is the first step to begin with. And I do take a minute to understand where the patient is coming from as far as what the thyroid levels are and what are we looking at, what is the clinical situation. It helps me understand, because even if it's for a focal thyroid nodule or even if it's for a diffuse thyroid disorder, understanding the clinical scenario definitely is a very helpful point to begin with. Just a case one, which is a patient who's sent in for a routine ultrasound. It's got a T4 levels, which are 3.56, which is a high result, T3s, which is a high risk, and a TSH is a very low, and has been sent to me for a thyroid ultrasound. So what do I see now? That's the ultrasound. So I see that's the midline, the isthmus, which looks a little bit bulky, and thyroid gland per se, as compared to what we just saw, appears diffusely hyperechoic. And remember the contours that we looked at, they were kind of concave. These are all not straight, but they are convex and they are bulged. So there is a diffuse thyromegaly that we can appreciate. There's a diffuse enlargement of all the throat. That's the right lobe. That's the right lobe in longitudinal side. And the interesting part is we see patchy hyperechoic ecotexture, and the important for imaging professionals is to figure out when do we see the pseudo nodules and when we see the true nodules. So that's the challenge in thyroiditis. Often that's one area where you often find controversial reports where there is not an actual nodule, but it's been reported as a nodule. And often when there is a nodule, it's actually not reported as a nodule. So here, like for example, if I could say maybe Percy, come on, create a nodule here, that wouldn't be appropriate because that's actually kind of a patchy hypoechoic texture. So of course, so the values were done, and this was basically thyroiditis, which significantly increased vascularity. And of course, nuclear medicine scan was also done, and that was confirmed and managed accordingly. So case number 2, so we have a T4 value of 2.1, T3 value of 3.3, and a TSH value of 0.944. And let's look at what's the ultrasound findings that we have. So we have a thyroid which is very heterogeneous kind of an appearance. So this is like a coarse or a heterogeneous parenchyma, and of course it's enlarged and a coarse. Now, such kind of a thyroid, it's often a challenge to actually begin and figure out if there is a true nodule as well hiding. So that's the challenge. Of course, there's an increased vascularity. There could be sometimes a real nodule as well hiding in midst of the thyroid parenchyma. That's the imaging responsibility or liability to look for these nodules, and if they have any suspicious characters, of course, to suggest for an FNA. These ones are looking like a pseudonodular appearance. However, differentiation is very, very important, and that's the key. Of course, ultrasound shows enlargement, and there was a hypoechoic nodule which was taller than wide and was reported as TR5. And however, I think the patient underwent thyroidectomy. That was the management in this case. And of course, the nodule was probably benign. It was lymphocytic thyroiditis with multinodular colloid goiter. Nothing suspicious or nothing neoplastic on histopathology finding. So, learning curve. So, of course, the thyroiditis and lymphocytic thyroiditis and Graves' disease and Hashimoto's, these are the most commonly encountered disorders that we see in our everyday practice. And an ultrasound, thyroiditis, we get the patient sent for ultrasound. So that thyroiditis is a big spectrum, acute, subacute, chronic, and vascularity and anti-TPO antibodies level kind of often do go, the activity goes hand in hand. So often we are as a marker or an indicator to the management and to the response to the treatment. So the vascularity assessment, of course, your equipment settings, Doppler settings, your expertise and your experience do go a lot, but benchmarks, of course, when we took our parameters, we set them with the carotid vessels, and understanding the vascularity and giving a correct opinion is important. That guides the treatment. Coming to the next, chronic lymphocytic thyroiditis. So this is interesting. So in this case, the one side of the thyroid gland is appearing quite normal, the right side. And like usually we see bilateral, right? This was a very interesting case where it was unilateral, right? And that's when you think, okay, are we dealing with a neoplastic situation by any chance, right? So here's the right side that looks all right. Here's the left side that looks quite hypoechoic, quite abnormal. However, let's continue the scan. The right side looks okay, right side looks okay, right side looks okay, normal vascularity. Left side looks very heterogeneous, hypoechoic, and all inflamed. There's no true nodule as such that we can pick up, but probably maybe some pseudonodular or a nodular appearance and with some echogenic fibrotic strands that we can appreciate. Of course, mild vascularity. So this was probably chronic lymphocytic thyroiditis on one side. Elastase showing a little bit of firm consistency. So that was the ultrasound report because of this atypical appearance. Of course, FNA was suggested, and I think CT was also done, and everything was done. Finally, the patient had an FNA. It was with histology category 3. And I think then finally the patient did undergo surgery, probably. I don't have that follow-up here. Coming to the next case of Graves' disease. So what do we have Graves' disease commonly? We have a diffusely enlarged thyroid, or it could be normal. And of course, the most significant finding is a thyroid inferno or really profuse pattern of vascularity. So that's, of course, clinical picture we all know. There's a elevated hormone. So that's like a classic picture of Graves' disease, and that's a thyrotoxicosis. And we are doing a thesis work with Dr. Vishnu Priya. We are getting the inferior thyroid artery PSVs and RI values, and to see if they could be a factor in our diagnostic yield and save the nuclear medicine scans maybe years down the road. Let's see. So we have PSPs of 40 or more, which has 96% sensitivity and 85% sensitivity for Graves' disease. We're trying to get the data, our own institute's data for the same. And I do see PSPs over 30, 40, 50 as well, recent cases that I've just done. So let's see where this data takes us. So of course, what's the role of ultrasound? We are going to look at the Doppler values and the peak systolic velocities and look for hidden nodules, the pseudonodules and the real nodules. And when you see the real nodules, what do you do next? You do the TR scoring, the thyroid scoring. So, and the other characteristic pattern about the thyroiditis is the patchy infiltrates, like the patchy, you'll have them like often on the lateral edge, or the infiltrates very patchy. And in chronic Hashimoto's or lymphocytic thyroiditis, you will have these fibrotic ecogenic strands that you cannot really identify in long-standing chronic cases of thyroiditis, really like a fibrosed gland, like basically. And the vascularity will depend on the activity of the disease, which can be low, mild, or more. So this one is showing a good bit of vascularity, and also at the same time, we have significant level 6 lymph nodes on both the sides. So corresponding to the activity, that's another L6 lymph node that we see here. So I think that's another case which is pretty much got a high result for T3 and a T4 and a very low TSH. And of course, it was diffusely enlarged thyroid. Now, the challenge here comes is looking for any focus of micro PTC. Now, if I try and look here, maybe I think I can see teeny calcifications, teeny micro calcifications. So like basically you have to take the microscopic, we have the microscopic vision to suspect. So see these subtle, calcific foci. So I'm not really very happy with this, just to let go of it. So this is then again, if I go, it's not there, but there are more foci and they're more, this is a bigger one, which may not bother me, but still this was, I think, very heterogeneous, and it was finally sent for FNA, which probably the patient did have surgery anyways. So what we have seen is we have to see the vascularity. I'll just come to cases for the nodules now. Antibodies, these are clinical factors which you, okay, so the hallmark of Hashimoto's is we have this classic fibrotic and honeycombing kind of an appearance, spongiform pattern. That's a classic case. This has been sent to me for a chapter. So I'm grateful I've written one chapter on thyroid ultrasound imaging for Professor Anand Mishra at STPGI and one for Dr. Madan Kapre in South. So that's images from those texts that I've sent. So of course, coming to the next, this was another interesting one. So we have the same Hashimoto thyroiditis pattern, but only on one side. So one side looks all right, but on the other side, so again, these are like, okay, interesting. So one side is quite enlarged. So typical those honeycombing appearance, and the other side is pretty much normal. So you can have varied appearances. And of course, the biopsy, I think, was done, and it was features in this benign follicular nodule on the left side. So which was like maybe a large spongiform nodule. Which was occupying almost whole of the thyroid gland. That was it. So readers, we've not yet to see. Atrophic is often when your patients are on long-standing thyroid medication, the gland itself is just put and shrunken and atrophic. We hardly, I mean, these cases are interesting. Sometimes there's a large parathyroid adenoma, and interestingly, it can be mistaken for a thyroid when the thyroid's been almost done redundant with 25 years of thyroxine treatment. So that's when you have to figure out what is your thyroid. And often when there's large nodules, it kind of overshadows from one side to another. So the ground rules are back again to start with your basic anatomy, start with your midline, and then you evaluate the structures and just go in sequence, and then you'd be right. A challenge is to look for little nodules in finding a PTC in thyroiditis, because again, so ultrasound is a relative contrast. We are all working between the shades of black and white, right? So all the diagnosis between those shades. Now, the background shade is altered. So what pathology we have to pick up, that's another further challenge. So let's see how we see. So we come to the thyroid scoring for the same, and that standardization. There are different kinds of thyroid scoring running all across the globe. There is European thyroids, there's Korean thyroids. What I usually follow in our department is the ACR, the American College of Radiology thyroid scoring. So what that does is, like, for example, let's see, we are beginning a scan. We've got a little nodule there that looks like a solid lobulated mass. Let's see if we can figure out what the scoring is and how do you think. Its margins are a little bit solid. It's definitely solid. It's definitely hyperechoic. It's probably got lobulated margins. Doesn't look like a simple benign nodule to me at all. And then, of course, it's probably got these 3 little dots that look like microcalcification of punctate foci, maybe. Again, I'm very suspicious by the time I see these. They're very suspicious. Again, look at the margins. Look at this. Typical PTC is what it's looking like to me on basis of my ultrasound appearances. But however, how do we communicate and how do we standardize our reporting system? We move to the thyroid scoring. AI is also coming in a big way to do all this. So that's where we come to the American College of Radiology, which gives a scoring system, what to do, when to do. Right. So how do we do the scoring? Based on the various ultrasound features, which is a very long, detailed study. We are doing case-based today, but however, these are the composition, whether it's solid cystic, echogenicity, whether it's hyper or hypo or iso, shape, what is the shape, what are the margins, and what are any presence of echogenic foci or calcifications, and lymphadenopathy, the most important area as well. So, of course, if there are multiple nodules, we have to document the most suspicious looking nodules, not by the size, not by any other features. Often micro PTCs will have multiple teeny, very suspicious nodules, right? And these are just the assumptions. And this is how I follow the protocol to do the reporting with all the descriptors and then add and you get the thyroid score. This also gives the referring physician an opportunity to compare it with the ATA guidelines. So when we have the descriptors included, that's like a uniform, universally accepted language of conversation. And going forward, if all do that, we will not have any discrepancy in reporting and it will all be standardized. Now let's look at some cases with nodular lesions. So case 1 is a 57-year-old female with a swelling in the neck on the right side. And what do we see? We have this, this is a large lesion. So we've used a seascape or a extended or a panoramic view mode of ultrasound imaging to depict that whole thing. So here's the trachea. That's a transverse view because I've got the trachea, I've got the CC and IJV in a transverse view. That's the whole of the neck in transverse. It's like a large lesion, which is each of this is about 1 centimeter. So that many centimeters, it's like draping around the neck. So it's a large lesion that is there on the right side, which is extending from midline here to the lateral side and it's almost displaced in the trachea and the IJV on the right side. That's about 10-12 centimeter size lesion there. Okay, so that's a lesion. It's solid and cystic, predominantly solid maybe, and or with a cystic component. So, and now if you look at this cystic solid component, do you think we can see maybe some suspicious microfoci? Maybe. That's the isthmus. That's the left side, which is pretty looking okay. It's got some vascularity. Vascularity is not a feature in thyroid scoring though. And then, of course, the area that concerns me is the low. We have some microechogenic foci there, and the area at the lower pole was very densely shadowing and had some foci of calcifications. I think I gave it a thyroid 3 and a 4 or a 4. This area was quite suspicious here on along the lower pole next to the isthmus. There was a focus. So finally, post-op, it showed follicular variant of papillary carcinoma and well encapsulated, right? So, and the patient underwent right hemithyroidectomy first, and with that FNA, the patient underwent completion thyroidectomy constraint. So, because I think pre-op it said pre-op histopathology was also probably Bethesda 3 or a follicular variant. Okay. Right, next case. So what do we have here? We have a nodular swelling 3 centimeters in the anterior midline neck, for mobile, non-tender, moves with deglutition and no palpable lymph nodes, FNAC and outside, shows suspicious, and repeat FNAC at our institute, reviews a PTC. And on CT, of course, we have a lesion there that is there. Now let's look at the ultrasound. So what's this? This is the submental region. We have the midline. So and that's the tongue area. So in the midline, we have I'm just moving a little bit down. We have a large hypoechoic cystic solid lesion and with multiple echogenic foci within. Now, these are classic PTC punctate foci. These are classic PTC punctate foci. And of course, when I'm saying it's a midline swelling, and I'm sure the diagnosis is pretty obvious to most of us all here. So, and this is what we call as a color twinkling artifact, which we see often in color Doppler behind calculi. So this is classic punctate echogenic calcific foci in a patient that's like a neck. We are just trying to scan in the midline, and that's it. So here's the, you can see classic lesion. So, and that's the gland itself. That's a gland itself. It's okay. So that's longitudinal scan now. So we see this lesion going down there, going down there. So diagnosis, anybody wants to write in the chat, you're more than welcome to do that. However, the diagnosis is pretty obvious. So it's a PTC in a thyroglossal cyst, so which was a very interesting case. So yes, patient underwent total thyroidectomy. Not, yeah, total. Because, yeah, total thyroidectomy plus excision of the cyst. That's the next case. Now, this case is interesting. So you put your probe on the midline and you see enlarged isthmus and just both the lobes, and both the lobes are filled with multiple punctate echogenic foci. Punctate echogenic foci simply have a 3 scoring number. So it straight away takes you to Thyroid's 5 level, right? So this is classic PTC. Right, so we have numerous punctate echogenic. So this is a bit of the normal thyroid parenchyma on the right, but basically all is involved here. And we cannot definitely comment upon extrathyroid extension in this case. And I think this patient underwent extensive surgery. So with a fascia peel, bilateral central compartment exploration, and parathyroid implantation. So because of the like the disease is extending from capsule to capsule, right? So this is another thing. Not all lesions in the neck are from the thyroid. There could be things beyond that as well. So I've written the diagnosis here. This is interesting. It was mats from prostate as well in the neck. And it also had an FNA of Hürthle cell neoplasm. So this was an interesting. So both the findings were there. So let's look at the neck ultrasound. So we have normal looking probably the left, but we think we have a nodule on the right, and we have a nodule and which has some echogenic calcific foci there. And it was a Hürthle cell neoplasm on FNA and elastography. This is the lymph node. So it also had lymph nodes on the neck, which were showing heterogeneous vascularity, typical of a metastatic lymph node appearance. Of course, these were metastases from the CA, and that one was the primary in the neck, Hürthle, another one. That's a classic vasculature of a neoplastic lymph node. So metastatic CA prostate with FNAC approval, Hürthle cell neoplasm. So another case, last case for the evening. Thank you all for staying up with me. So here's a left supraclavicular lymph node, so which is heterogeneous. It's got cystic component. It's got a calcific component as well, and it's got a heterogeneous vascularity. And Again, it's got a heterogeneous vascularity. It's hard and elastography, firm to hard and elastography. And of course, this was just a primary from a CA breast, and which was proven metastatic CF. So think beyond and do your groundwork in detail. A thorough scan from wherever your windows can be. Like I would go right up to the jaw, I would dig into the jaw, dig into the substernal region, dig into the clavicles, whatever I can. So to get as much information as I can. We have very nice small footprint transducers now. We can really dig into the paratracheal region, the sternal region, and even those lymph nodes that we evaluate, and it changes the planning level and gives a better prognosis to the patient at the outset. So thank you, everyone. And thank you, Thyroid Society, again for inviting me. I learned a lot today. Thank you so much. Thank you.
So thank you, Dr. Alka, for wonderful presentation. So we have few questions in chat box. Shall I read those questions? Yeah.
Yes.
So first is that few times when thyroid is very obviously enlarged, but the radiology report it is reported normal. So it's the error, or it's you have a different way of reporting. So that's what the Dr. Neelam probably want to ask.
So the normal size by the age and by the body status of the patient, habit, body mass index is another good question, but I just give the measurement, and I quote enlargement when that's the point I actually stressed in the beginning of my presentation. When I see the thyroid contour, it's like a concave kind of a contour, like, right. If I see the margins have been straightened, if the margins have been diffusely bulged, I'll call it megally or enlargement. It's not about the absolute number. It's more about the contour and the way it looks like. Even like how I look at the kidneys also. Kidneys have got a very lobulated cortical outline, but if the patient's got nephrotic syndrome or something, if it's swollen, it's not about the absolute size of the number. That will vary with patient to patient. But the overall subjective appearance and the feel of it, I will say the contour, bulge, diffuse enlargement, and these are the numbers. The numbers will vary on the age, stature, and various factors, because that data literature I've tried, because I've written chapters for people, so I've like gone in and out through almost whatever is available on the net for the same. Yes, but those are the features I use and which work mostly.
Thank you. So another question is that why is the vascularity increase in thyroiditis? Because for endocrinologists, the biggest thing is to differentiate between hyperthyroidism and the thyroiditis. And the biggest challenge we face, especially in the people when they are on amiodarone or cordron, they've been using. And we rely only on the thyroid ultrasonography, and we write for CFDS, color flow Doppler study. But how you can help us in people, because the vascularity increase in both thyroiditis, you call it thyroiditis, but for us, it's the challenge is that to differentiate between thyroiditis and the hyperthyroidism. So that is the challenge. And we say endocrinologists feel that the vascularity increase in the grapes. So how do you differentiate between the two?
I would also look at the lymph nodes.
Okay.
Status, because in cases of Graves' disease, I may not see many enlarged lymph nodes, but in cases of thyroiditis, when there's an autoimmune process going on, I will usually see associated at least levels with bilateral lymph nodes. Because I comment on that. Those are the scenarios, because I will only per se see the vascularity, but vascularity plus lymph nodes may mean something else for you. Vascularity, just vascularity and no lymph nodes may mean something else for you. So I would just document my findings per se as to what I see, and I'll leave you to do your maths.
Then final question probably in the chat box is how to locate the inferior. There is one more. How to locate the inferior thyroid artery. So
that's an interesting one. I'm doing the thesis on it. So, that's core radiology.
That's hardcore radiology question.
There's one more, Sunil. Which grading system is better for nodules? But I think that has been very clearly defined.
Yeah.
The thyroid.
Yes, the thyroids. Yes.
So, Nisha, are you there?
Yes, Dr. Nisha.
Dr. Nisha?
Yes, madam.
Yeah, actually, Dr. Hazra has two questions from the earlier presentation. I think we can take those as well. In that, I don't know, Ghazal, is Ghazal there? Sunil, perhaps because it is your study, right?
Yeah.
Any data on iodized salt intake, Dr. Hazra wants to know.
Okay. So they were commenting that their iodized salt intake, but probably we don't have that kind of the information that the amount of the salt and the type of the salt. It is very difficult to get the non-iodized salt nowadays. So everyone is thought to be using the iodized salt. But the problem is that the amount of the iodization that is going to the population at the end of the end user is the challenge. Most of the iodization is lost during the transportation and the reaching to the end user. So that may be thing. Ghazal, was there any comment about the iodine use in that?
Actually, the survey they did, in that survey, they found that they were using iodized salt only. Yeah. But the amount of salt and the final quantification of iodine was not done.
Yes, it was not done.
Okay, the other question from Dr. Hazra is any correlation of iodized salt exposure and positive thyroid antibodies, especially anti-TPO?
So they excluded probably, ma'am, the autoimmune disease to begin with. So these were the population where the antibody were positive pregnant ladies were excluded from the study. So, and all were them presumably using the iodized salt in an appropriate manner, but the iodine, if you look at the iodine, urinary iodine excretion, it was most of them up to 90% were reaching up to the iodine deficiency in the end of the third trimester. So that is what. So we probably can't answer this question, Dr. Hazra's. Yeah.
Nisha, there's another very broad spectrum. I think there are two questions which I forwarded you. Because this is from another chat box, which is not apparently.
So the question is, if trimester specific TFT values are not available, then can we consider second and third trimester reference values to non-pregnancy TFT values as per ATA guidelines? I think if you don't have, that's what we all follow. If we don't have our own population specific TFT values, we follow what the ATA says. It is 0.5 less than the upper limit of normal for that assay. So generally, if it is 4.5 non-pregnant, we take 4 for pregnant ladies as the upper limit.
And again, a very routine question, but I'm sure Dr. Saeed Yusuf Kaman wants to know how to treat subclinical hypothyroidism without any symptoms found to be TSS 6.02 on screening. And the queried yearly health checkup. This is his question and comment or answer or whatever.
So,
yeah, again, very straightforward.
Yeah, Ghazal, can you answer this? Yearly health check, not related to pregnancy right now. So, yeah.
Not audible.
Audible is, you are not audible.
Am I audible?
Yes, better.
Actually, in such patients, we'll go for if they have no symptoms, we'll go for the autoimmunity status. And if the anti-TPO levels are positive, then we can plan for further treatment. But if the TPO levels are not positive, then we don't recommend treatment.
So what's the chance that the normalization will happen over the years, and how soon and how long the normalization can happen? And what proportion of the people the normalization has been reported? Because these are some latest updates on that.
So for normalization, around actually 30 to 35%. I'm not very sure, but this is the last which I normally.
Nisha, would you like to elaborate?
Yeah. Yeah, it is usually one, that is the rough teaching, that is 1/3 will remain the same, 1/3 will normalize, and 1/3 will progress. And even studies have even shown that anti-TPO positivity also, the progression is not that much. So the absolute indication to treat subclinical hypothyroidism is probably pregnancy, or planning pregnancy with anti-TPO positivity, or in a for to improve the cardiovascular mortality in cases where there are high risk for cardiovascular disease, like they have a lot of risk factors like diabetes, hypertension, and they are at high risk. It has been shown that subclinical hypothyroidism treating more than 10 is shown to improve the cardiovascular risk. So that is how, and if there is a nodule in the thyroid and you want to, then again it's a relative indication. So all these are relative indications to treat, but as I already said, a single value of TFT, you should not jump and treat. You try to repeat it. Even the guidelines say it has to be persistent elevation of TFT. And one thing you have to always remember, patient must have recovered from a recent respiratory infection. So a recovery of the CQ thyroid syndrome is the commonest cause of probably a raised TSS. So you ask for a history of recent URI or something, there may be a small suppression, and then there may be a rise in TSS, which is subclinical hypothyroidism. So that's also very important to ask in the history whether they had any recent infections which can contribute to the altered TFT. So you demonstrate a persistent high TSS, anti-TPO antibodies, goiter, and cardiovascular risk factors or pregnancy-related factors, and then you take a call.
And another age group is the elderly, where probably the little higher TSH may not be that harmful. It was thought to be protective.
Yeah.
So, and the normalization rate in the latest study in the 1 or 2 year back was, so 40 to 60% of the people may normalize over 5-6 years. So they may take a little longer. They may have persistently raised TSH like 6, 7, or 8. Below 10, probably you need not to worry too much about. So the question was asked about 6 or 7 TSH in absence of any other compelling indication which Dr. Nisha was talking about. You can wait and watch safely. Yeah.
Regarding the elderly, Sunil, I think what you're talking of is 80 plus.
80 plus.
But a bit above 60, there's some cognitive dysfunction, which may be associated, and that with subclinical hypothyroidism does warrant relative treatment to see if it improves. Again, that is a relative indication. And we published some data on that in the IJEM as well.
Yes.
The rate of progression, I think, is about 4% per year. So it's not big, but I think annual monitoring is fair enough.
Even the TPO antibody, the rate of progression is only 2.5% annually. And it's more determined by the raised. If the TSS is above 10, then the progression is a little more than even with the anti-TPO, beyond the anti-TPO.
Absolutely. One last question, very, very broad spectrum. Dr. Shamir from Shahjahanpur, how to protect thyroid problems? So I think we'll do the last question. So anybody?
So one question, and that's probably the general population keep asking, what are the lifestyle changes? So in one liner, what I have learned is that thyroid disorders are not lifestyle related disorder. So you can't do, and only the lifestyle thing is that you have to consume the iodized salt, which universally now available in India, and salt is available. Apart from that, one important thing, I was reading an article few months back, the chance of having thyroid malignancy, which probably Dr. Alka will be highlighting better, of thyroid malignancy is more in the upper lobe of the thyroid gland rather than the lower lobe, probably because of the more X-ray imaging or dental imaging it is happening. So if you see a nodule in the upper part of the thyroid lobe, it's more likely to be malignant compared to the lower lobe, Dr. Alka. So
I wouldn't think upper or lower has anything to do with it, but because when you get the radiation, upper and lower, the whole thing gets the radiation. In fact, actually, that's a very good point. The dental collars are not, their dental collars, what to do? That's the interesting scenario.
Yeah.
So that is a real question which actually comes up in my mind many a times, that some more stringent guidelines and regulations should come into place for the same. And I think you all can only take a charge for the same. Probably you have to reinforce a dental collar. So I'm sure any institute will provide dental collars every time, and a patient has to just wear it. That's just a simple collar. It's just a collar that you just wear it. It's upper, lower, it won't make any difference because it's just draping around the neck. It's just isthmus in the front. Whatever is it, it's a simple solution. Somebody maybe, because the thing is to collect such a data and to do a research and to do a study and to prove it, because we all know the thing is the guidelines can be given, but how do we collect the data and research and publish it? It's a challenge. Like either you put in a questionnaire every time when you have a thyroid and PTC, have you had any dental x-rays and how many x-rays in the past? Will they really remember? Have you ever visited a dentist and have you had any x-rays? I mean, either we add another column to our history taking and we track and we get the data out of public, and then we ask government to put in guidelines, or we just issue our guidelines. That's
especially since in children, when they become adults, they wouldn't know anything about their dental, and parents are very particular about.
You see 21-year-old, 23-year-old with PTC, and like you do wonder, like, I mean, I haven't asked people like, that have you had any dental x-ray, because before I ask a patient will ask me 10 questions then. So I better not ask any question like that to the patient, unless if you want to run a standard questionnaire and give it to all. That's a different scenario.
Thank you.
I think we are done with the questions. Can we go for the quiz answers from Dr. Tejal?
Sure, Dr. Pramila.
Yeah.
Should I just share my PPT?
Yes, you can share and you can next give the answers. Then you can announce the results as well.
Really? Okay. How do I know the results?
Asmita, I think will just tell you.
Yeah, I'll share the screen.
Should I just do the key first, Dr. Asmita?
Yes, please.
Yeah, please.
Right. Okay. Okay. So the first one, fluid with pseudostratified columnar epithelium is basically a thyroglossal duct cyst, which can present as a painless 1 centimeter mass in the anterior neck region, usually in a young woman. The correct answer was that the pre-op value in a medullary thyroid carcinoma, if it's less than 500 picogram per ml of calcitonin, and if the post-op value is less than 20 picogram per ml, it almost 100% says that this has been fully, the MTC is in remission. So the numbers are 520 and not 105. Rest, everything is correct. In this randomized controlled trial of the use of teprotumumab for thyroid eye disease, the cutoff was 2 millimeters reduction in proptosis and 2 points reduction in the clinical activity score. Rest, everything was correct. So the cutoff for the primary outcome was incorrect. Yeah, this one. So I was fascinated to know that hyperthyroidism is very common in cats, and that's why they have iatrogenic hypothyroidism because of overuse of carbimazole. The one which was incorrect is the dose of levothyroxine. In humans, we have like 1.6, 1.8 microgram per kg. In dogs, it's about 20 to 40 microgram per kg. So they require a much higher per kg microgram of levothyroxine as compared to humans. And I have a Doberman in whom hypothyroidism is extremely common. So we screen him every 6 months for hypothyroidism. For this, the plasma cell-free DNA in nanogram per ml, the cutoff was 67.9, which almost with 100% sensitivity differentiates between malignant and benign cells in a thyroid nodule. Carbon tetrachloride is not one of the pesticides which is linked with the genesis of thyroid cancer. This had come in the JCM advanced e-print or e-publication ahead of time. So carbon tetrachloride was the incorrect pesticide. This is, again, I said, thyroid research practice. The drop in TSH in the postprandial state in this particular study from the journal was 0.3. The TRUST trial was in elderly people, and the study found that treating patients who are elderly with subclinical hypothyroidism with levothyroxine did not improve symptomatology to a significant extent. So the study was negative. It was in elderly people. And last is the diffuse sclerosing variant of PTC. The red PTC rearrangement is the most common molecular alteration in this kind of papillary thyroid carcinoma. Thank you very much, Dr. Pramila Kalra, Dr. Sarita Bajaj, Dr. Ganvi, for the kind invitation. And thank you so much.
So I think, Asmita, can we have the results, or Dr. Tejal can announce?
Dr. Pramila, please go ahead. You or Dr. Sarita can.
No. You are always the quiz master has to announce. It's the rule.
So congratulations, Dr. Parag Agrawal, Dr. Nevin, and Dr. Syed Farooq Ali. And it's so amazing that on a Wednesday evening to see 60 plus, DM students and residents all kind of participating in the thyroid quiz. So congratulations, all of you. And I had a very hard time finding the questions. So really credit to you. Thank you so much.
Thanks, Dr. Tejal. Thanks. So I think with this, we come to the end of today's thyroid clinics. And we had a very nice discussion with 2 journal clubs. And then we had more of insights from Dr. Alka on thyroid ultrasound. That was really very good. We all learned a lot. And I think everybody learned a lot. And Dr. Tejal's questions were very interesting. So I just leave it to Dr. Sarita Bajaj ma'am to give her final remarks, and then we close the session.
Yeah, so thank you, Pramila. Thank you for being with us, and she's the scientific chair for all the thyroid clinics, and very, very good support for all the meetings that we've had. I think Arun is also there with us, and Minnie. So these are our faculty whom we have for every meeting. Thank you, Nisha, for the wonderful moderation. And I think both the journal clubs that we had, presented by Ghazal and Vishnu Priya, very, very good learning points from both the journal clubs in the context of iodine, subclinical hypothyroidism, pregnancy, outcomes. Of course, there will always be some unanswered questions. And I think it is high time we had population-specific data. I think, Sunil, perhaps because you've done, I think this was a 3-year project that you did?
Yeah, this was 5 year, ma'am. This was
5
from
years. Yeah,
5
so
years. This was
5
PhD
years.
student, Dr. Nikku from APJ Satya University was, and Dr. Asha Chandola. Dr. Asha Chandola has done she is very senior person, and she has done her studies in the birds and wrote in Europe, and at that time around 50s and 60s. So she was keen to do this project.
I think that's a wonderful contribution, and it's an excellent publication as well. And of course, Addison's disease per se is not so common, but again, we've had some learning points from that as what is the association with hypothyroidism, Graves' disease, type 1 diabetes, and whether the patients should be screened or not. So thank you, Nisha, for moderating both the journal clubs, and thank you for Medanta's contribution, Sunil. Both the journal clubs were excellent.
Thank you for allowing us.
Yeah, thank you. I like my faculty to work hard. So Tejal, thank you for the wonderful questions, which you were able finally to dig up. I'm sorry I had to push you a little because even though you were not well, I hope you're feeling better now.
I'm absolutely okay, ma'am. The push is totally okay.
And Tejal, if you know, she writes wonderful blogs. At least I look forward to them. And each of them is unique. They address, it's the very common issues, but we are not able to express them. So Tejal, please continue writing and forwarding them in the groups. I would suggest that all of you need to read them. And, think of your undergrad, postgraduate days, as well as what practice is all about. So very, very practical. Thank you, Tejal. From the digital team, we have Mansi with us every time. Thank you, Mansi. And from Medicaid, we have Priyanka with us. Thank you, Priyanka. So thank you all very, very much. And we have our patrons with us. Dr. Prasanna Kumar was there. Thank you. Thank you, Dr. Prasanna Kumar, for joining us. This is the next thyroid clinics, which we'll be having on the 17th of August. Thank you, everyone.
Thank you, madam. Thank you.
Good night.
Thanks, everyone. Good night.
And Dr. Singhal, of course. Dr. Alka Singhal's talk was amazing with very, very excellent value add points. Thank you, Dr. Alka. Thank you so much for joining us. And Sunil is right that your contribution to thyroid ultrasound makes a tremendous difference as far as ultrasound and radiology in thyroid imaging is concerned. Thank you, Dr. Alka.
Thank you. Thank you.